I'm on holiday, Alan. I'm in north of England.
Oh, nice. You're on vacation?
Yeah, on vacation. We brought our bikes and our dog, yeah. But it's rainy and blustery. My husband's gone out for a cycle because he's mad. I said we'll go out later.
1 second. Let's go to Facebook now.
Let me turn on the light here. Give me 1 second.
Okay. Oh, that's better. That's better.
Okay, that is us.
We are
live on both Click Meeting and Facebook. So I hope you have a good session, and I will catch up with you near the end of the session.
In a wee while, as you say, Ned.
In a wee while, yeah, in a wee while.
Okay, thanks, Alan.
Cheers.
Good afternoon, Dr. Bond and Alan. Good afternoon, everybody, wherever you are. I know we've got somebody from blustery Yorkshire. I'm just 100 miles up the road, blustery and rainy here too. Welcome, everybody. And I'm going to, Alan, we haven't seen you for, as you say, a couple of months. Do you want to tell everybody a bit about where you work, where you're from, and what you do?
So thank you, guys. I'm Alan Bonder. I'm one of the doctors who work at Beth Israel Deaconess Medical Center in Boston, Massachusetts. I'm originally from Mexico, but I've been in Boston for, I think, close to 20 years. My research interest in PBC, and I've been working with PBC patients also close to, I would say, 15 to 17 years. So here I am, and again, it's a pleasure to be with you again, Collette.
Oh, it's just so lovely. So we've got quite a few people in the room. I'm going to say a couple of things at the beginning, a couple of things at the end. I'm saying to everybody, you know, these things cost us money. Donations are drying up. If you please can donate to the foundation, we'd be really grateful. You can do so online, and we're going to be putting particulars out in various lines of communication. And also, many of you, and Alan, you might not have seen, I did a vlog the other day. I do one once a month, and so I will be hanging up my pen and my laptop. I am winding down, having founded this and been doing this for 26 years. So some of the trustees have formed a working party to find someone who replaced me as Chief Executive Officer. And please don't think, everybody, we're having an executive in who's going to change us. This is about PBC patients for PBC patients, and we're after that cure. So trust our trustees. They're goodies in there. They're good people, and we want our work to continue. So anyway, but with that in mind, I'll always be around. I'm sure you're not going to get rid of me that easy. Oh, okay. So I'm going to start you off now with the first question, a bit of background here. Recently been diagnosed as PBC. My partner and I have been trying to conceive for 4 years and decided to try a new IVF specialist. I fall pregnant, okay, but sustaining the pregnancy is just not happening, and I tend to miscarry around 6 to 8 weeks, and I'm really, really sorry. That's awful for you. The specialist investigated, noted my ANA was extremely high, and I went to see another specialist who diagnosed as PBC. Interesting, because it's normally the AMA, isn't it? It's the anti-mitochondrial antibody, but maybe we could talk a bit about the NA as well, Alan. So the question is, can an autoimmune disorder have an impact on fertility? If so, are there any medications that make pregnancy possible where the autoimmune disorder has impacted their fertility? So this is quite a monumental question, Alan. I would love to hear your thoughts.
So first of all, you know, I'm really sorry that that patient is going through that. I know it must be tough. And again, I'm going to say I'm not an obstetrician and I'm not a gynecologist, so I'm going to try to say there's no data to prove that PBC by itself will cause infertility. But, you know, PBC goes with other autoimmune conditions, as the patient mentioned. So, for example, things that come to my mind, celiac disease is one of the big ones.
Celiac
disease. The other thing with a positive ANA, you know, could the patient have antiphospholipid antibody syndrome, not related to PBC, but related to the other autoimmune things. Again, I think that needs a kind of thorough evaluation. But again, just if you want to ask me, does PBC really cause infertility? Unless PBC has caused advanced disease and cirrhosis, I've never heard that. And I think, Collette, you mentioned a little about the ANA. So it is correct. So most of the patients with PBC will develop a positive AMA, an anti-mitochondrial antibody, but there are certain populations, there are certain patients, they can develop positive ANA, and there are specific ANA, for example, the GP241, and now specific ANA antibodies, they're present in patients with PBC up to 30 to 40%. So this is not unheard of, and it actually is common to see it in practice.
Okay. So we're basically saying to this person, so 30-40% of people with the AMA have the ANA as well, but it's possibly, there's possibly celiac disease or whatever, which can affect fertility. But I think with this person, with a wee bit more information would probably be helpful. But you're more than welcome to, if you phone the office, you can be put through to me. We can have a chat and get some more information, and maybe see if we can answer more of your questions. But there's 7 liver units in the UK. I don't know where you are, where you live, but there's 7 particular units, and they have normally a specialist there who will deal with these kind of things. So it would be nice to hear a bit more. But I think what you have said, Alan, has been a bit reassuring as well, and that you would not tie in a PBC with miscarriage, and I know lots and lots of people with PBC have had lots of babies. So, that I hope that's helpful to you. But if we can help further, I'm more than happy to. So we go on now, next one. I've been a nurse since November 2020. ALP and ALT readings fluctuate between normal and above normal over the past year. Liver specialist now put me on fenofibrate. Is that right? Am I saying that? There's bezafibrates, fenofibrate tablet per day, 145 milligrams in the morning with food. Now, this is an interesting one. So after 2 days of taking, I came down with severe migraine, vomiting much earlier than I usually get with a migraine, as well as digestive upset. The day after, it morphed into a splitting headache on both sides rather than one-sided migraine, like a bad flu, and I felt unwell. My liver pain was worse, and I felt like I was having weird neurological symptoms where my thinking was all messed up. I did a COVID rapid antigen test late in the second day. Unfortunately, it came back negative. So the question is, have you heard of anyone having such a strong reaction to fenofibrate for the first time? And can your body adjust over time and the symptoms go away? And they go on to say, I've actually stopped taking it to give my body a break, but don't know if it caused the symptoms I experienced. And that's an interesting one, Alan.
So I would say most of the common side effects of fenofibrate are not what the patient is describing. The common ones are muscle aches, muscle pains, and usually can cause kidney function abnormalities. So the creatinine, which is how we measure the kidney function, will go off, and liver tests. Again, if you look at the kind of the entire package insert, the side effects, yes, there's some what's called GI distress, there's some nausea and vomiting. It's very unusual, but most of my patients that I've treated with fenofibrate, really it's basically a lab abnormality. And then most of them, if you combine with other medications, for example, combining fibrates with the statins for cholesterol, can potentially increase your chances of risk, adverse events such as muscle aches or muscle pains. But again, the clinical scenario that this patient is describing to us is not very common of fenofibrate side effect. Mm-hmm. So I will ask back to the physicians, or make sure that there is an evaluation for, migraines and other common things that maybe the patient will have, but I don't think they're related to PBC, and I think they're not related to the fenofibrate.
Fenofibrate. It's an interesting one. I would also say to this person, one of the most underused disciplines across the world are pharmacists. And absolutely have a word with your pharmacist as well. But I would certainly report this back to your doctor. I mean, Alan was saying that he's never heard of a connection in this way. So it may well be they want you to try again, or maybe bezafibrate or something of that nature, because there is another one, bezafibrate. And again, what other medications are you taking? Could there be an interaction? That needs to be, and your pharmacist, your chemist would be the person to ask. So I hope that's helpful. Stephanie Parker, Cami has questions. If you type them up on the screen, Stephanie, I've got a list here in front of me, and then Linda's feeding me more, and then I come to the screen. So I'll try and get any questions, get them all in. Okay, so yes, if you keep them brief, yes, please do. Right, so I've had PBC for over 10 years. I've been prescribed Urso, omeprazole, and thyroxine, and I'm an Urso responder. Happy days. I also have an underactive thyroid, gastric antral vascular ectasia. I'm not a doctor. Lichen sclerosis, arthritis, most recently diagnosed diverticulitis. You poor thing. I've always suffered bone pain, joint stiffness, and fatigue. Since before Christmas, these symptoms have increased in severity. And longevity, which has greatly affected my mobility and quality of life. My doctor advised me to take paracetamol and ibuprofen, which had little effect. So the question is, are there any medicines, therapies I could prescribe to help these symptoms? Vitamin D injections, antidepressants, particular painkillers?
Again, I think this is a really good question to ask. And the first thing to look into is this arthritis related to another autoimmune condition? And again, I think as I mentioned before, PBC is an autoimmune condition. It can go with other ones. So again, the rigidity, the stiffness, the pain could be a sign of rheumatoid arthritis. And again, maybe seeing a rheumatologist or a primary care to make sure they're diagnosed. There's certain antibodies they can look for. And I think before we committed to say this, there is one treatment for these things, I think they need to make sure they diagnose it properly so they have a really good and a proper treatment for that things.
Yeah, I mean, I'm sure, I'm surprised this person's been told they can have ibuprofen, because these are anti-inflammatory and they don't always sit well with people with PBC. So I would be mindful of that and maybe get that checked. But you ask also about antidepressants, and we do know that some people cope better with pain with antidepressant, or there's a particular medication, which the name escapes me. It could be given in small doses for pain, but a much higher doses than antidepressant. I can't remember the name of it. Is it ringing bells with you, Alan?
From gabapentin, amitriptyline.
Amitriptyline, that's the one, amitriptyline.
Yeah, I think, Collette, I think you bring a good point, but again, before saying and committing someone to the pain is related to depression or antidepressive to mitigate the pain, I think that patient needs to be, that needs to be investigated and actually diagnosed properly, because you don't want it to commit a treatment without knowing what it is the cause. If there's no really good cause, then I would say, yes, it's better to maybe use occasionally anti-inflammatories, or maybe use some other pain modulator medication. But right now, with this information, I think that needs to be investigated a little bit better.
Yeah. So further tests, but yes, there are things that can be more helpful to you, and maybe reviewing the ibuprofen. So I think it's a good summation there. Now, I'm going to ask you this question, and I'm going to butt in first, okay? I have PBC. I've now been diagnosed with Sjogren's disease. I'm really upset about this. Is there any advice, information you can give me? So may I, Alan, say there's very, very common for people with PBC to have Sjogren's disease, and I was diagnosed with Sjogren's long before PBC. This is not a serious complaint, or this life-threatening anyway. It's at best inconvenient, at worst really bloody annoying. But there are things you can do. If this is in your mouth and your eyes in particular, use eye drops that are, if you can, oil-based eye drops, because and you can have a lubricant put in your eyes at night, and that helps through the night. You have 2 sets of tears. So when you go out in the wind or when you cry, you have tears. But every time you blink, there's water there that will cleanse your eye, and we don't have enough of that water, or any for some of us. So it's important that you keep good eye health by using drops. But again, speak to the specialist, the rheumatologist, or your optician who'll keep you right. With regards to your mouth hygiene is so important. Be wary of chemical mouthwashes. Do not use chemical mouthwashes in your mouth to clean your mouth. Use toothpaste, warm salt water. Chemical mouthwashes, they will stain your teeth. they will distort the taste of your food, but they'll also distort the chemicals in your mouth and could make it worse. So do not do that. But there are various things that your dentist can tell you about and your doctor. But Sjogren's is livable with. I will say that to you. So I'm going to hand over to you now, Alan.
I think you bring up a good point, Collette. It's very common. Up to 30% of people with PBC develop some type of Sjogren's syndrome. So again, dry eyes, dry mouth. I think you touched really the important points about what to do. I think number one is the oral hygiene is pretty good, but drink a lot of water. Try to keep hydrated is one of the big ones. And then for the dry eyes, yes, eye drops is the big one. I mean, sometimes it's very unpleasant, so then sometimes need a little bit more treatment. There are certain eye drops, that immunosuppression eye drops, they can help you with this. But again, I will let the kind of rheumatologists get involved with those patients and then basically address with that. But I think it's, this is part of the, I would say, the PBC autoimmune kind of syndrome, and it goes with it. And again, there's nothing to do. It's, only is we need to address the symptoms that are very uncomfortable.
Yeah. That's great. Thank you. So next question. I've been told to have the M2 marker for PBC. So have there been any trials done given patients as yet without symptoms? An anti-inflammatory drug, such as those given to rheumatoid arthritis patients, as this disease seems to be one of the markers of the active disease. So I'm not sure about M2 and M4 markers. Normally, if you don't have symptoms, they tend to leave you alone, but I'd appreciate a comment from you, Alan.
So the M2 markers is the specific anti-mitochondrial antibody portion. So that's the M2 part of the anti-mitochondrial antibody. So that's that's exactly the assay we're tested for. And again, when you are tested for M2, it's another test to diagnose for PBC. So if you have a positive M2 or anti-mitochondrial antibody, you most certainly have a diagnosis of PBC. And again, if you don't have symptoms, you only have mild elevation in your alkaline phosphatase, then you need to be treated with Ursodiol as someone who actually has the condition. So again, it doesn't change the type of treatment. It doesn't change the type of directions we're heading with those patients. It's simply a different marker to actually diagnose with PBC. And again, based on the M2 antibody, there is no specific treatment. So anti-inflammatories have been used in the past. I mean, if we actually look back at the PBC history in the 80s and the 90s, they tried colchicine, methotrexate, you name it, cyclophosphamide, cyclosporin, and all those anti-inflammatory markers never work as well for PBC as we have currently with the Ursodiol.
Okay. Thank you. Our next question, I think, is from an American. So this person says, I'm getting conflicting recommendations from two different doctors. Well, I'm really sorry to hear that. Both gastroenterologists, hepatite liver transplant specialists, and this is really difficult if this is what's happening. So they have stage 4 cirrhosis of the liver because of PBC. One says I should be taking Ursodiol, I think you call it, and the other says I should not. I've had severe pruritus, and one thinks that Ursodiol aggravates this and feels that at any point of my disease, Ursodiol wouldn't be effective anyway. Is there any opinion information you can provide? Oh, bless you.
I mean, I don't know the context. So first of all, if the patient is able to take Ursodiol, there is tons of information saying even if you have cirrhosis, stage 4 on the biopsy, the Ursodiol still works, preventing of you going from a compensated state to a decompensated state and needing a liver transplant. So Ursodiol should always be part of your treatment option. Should be the first line therapy for someone who has PBC, unless the patient is not able to tolerate Ursodiol. For example, gastrointestinal symptoms are the big ones, or headaches. So I do have patients that are not able to do that, and then I do take them off and offer them second line therapies or actually research options. Again, remember that cirrhosis is not a diagnosis equals dead or equals transplant. We've known, and what we know today, that we can keep patients with stable cirrhosis for years as long as they take their medications, as long as they're doing their screening tests. So my advice would be that, based on their condition, unless there are contraindications to take Ursodiol, such as side effects, then I will continue to take it. And then I think the pruritus, again, you brought another really good point. Up to 70% of people with PBC have some type of pruritus and can go from really mild to something that is really affecting the quality of life. We also have really good new treatments for that. There are Ursodiol, I would say, is not the best medication for that, but then we can use, for example, chloramine or bile acid binders. We can use antihistamines. We can use even rifampin, which anti-tuberculosis medications. And all those medications work, I would say, very well, and work well enough to actually improve your quality of life. And again, if pruritus or the itching is not getting better, they should talk to their providers to see if liver transplant is an option. But again, I would say that based on the new medications that we have available, even fibrates, we are able to control itching pretty well.
Yeah, excellent, good. It's a very simple question. My blood pressure is all over the place. Does PBC cause blood pressure problems?
The answer is no. I mean, unfortunately, PBC is a diagnosis when someone is in their 40s, 50s, 60s, and this is exactly when other comorbidities come up, like high blood pressure or diabetes. So my best thing is go to your primary care or general practitioner and make sure that you measure your blood pressure. And if you need treatment, you should start treatment. That will not change the PBC outcomes, and that will not change the PBC natural history.
Yeah, okay. I take 500 milligrams of Versol twice a day, so that's 1,000 milligrams a day, but you can take it all at once, by the way. You don't have to have it twice a day. I've now been diagnosed with osteoporosis and taken risodronate, sodium, 35 milligrams a week. Would I be able to take marine collagen powder twice a day in respect to PBC as a source of calcium? And should I continue to take the vitamin D supplement?
So there's a couple of questions, there's a couple of points that we can make. So PBC goes with osteoporosis because the way it works is PBC over time, you absorb less vitamin D. So everyone should be in a vitamin D supplement these days. And again, it depends where you live in the world. The northern countries, for example, in Boston, even in England, I don't think how much sun we get. So I think that's something that needs to be on our daily supplements.
Yeah.
Number two is patients with PBC should be assessed for osteoporosis. So I would recommend bone mineral densities every 2 to 3 years. And if they have a low density osteopenia, we would recommend those patients going in calcium and vitamin D and being a little bit more aggressive, changing lifestyle. For example, what we've known that smoking is a big risk factor for osteoporosis, and also not exercising. So we would recommend people doing some weight-based strength exercises, walking, because the more you walk and quitting alcohol and smoking will improve your bone mineral density. And people who have osteoporosis, we do recommend treatment. And I think you brought one of those new medications. So the alendronates, all of them, you use them once a week. They're really good medications. Basically, once you start getting them, we will expect the improvement of the mineral bone density within 1 to 2 years. But it's very important, if it doesn't improve, there is different other medications that you can use.
Yeah. And I think it's important to say as well, I mean, I get a DEXA scan every 4 or 5 years or so, and I'm okay, but they go into your diet very thoroughly these days. They didn't in the old days when I was first diagnosed. And I don't like milk products very much. And they pulled me on that and said, you've got to be careful here. You've got to keep your calcium up. And they said to me, maybe have an extra slice of bread a day or something. So what I would say to people is check on Google, what foods are good at calcium, and try and incorporate those in your diet. And I don't mean biscuits and chocolate. We're not talking about nonsense. We're talking about good quality food. But do bear in mind that your diet is as well as exercise, weight-bearing exercise. Swimming won't cut it. Walking does. But do bear that in mind, that that's an important factor. I see on the screen here, Stephanie is saying, does the PBC cause stiff and aching legs? I've been told not so by my consultant. What's good for this also, how can you tell if fatigue is caused by PBC rather than general fatigue? I would say one thing before Alan answers. I would say to you that fatigue is fatigue, and you will kill me for saying this, but the best thing you can do for fatigue is use movement as medicine. I heard a doctor in Canada, I can't remember his name now, 20 years ago saying, oh, I tell my PBC patients to exercise more. I thought, he's mad, doesn't he know how tired and fatigued we are? He's absolutely right. He's absolutely right. And the more you do, the more you're able, and get yourself a little routine. And you can go online, or you can give me a ring and we can talk about it. But walking, if you can hack 10,000 steps a day. And you know what I do? I have earphones. I'm on the phone a lot and I walk around. I just walk. When I'm talking and walking, I do talk a lot anyway. But movement is absolute medicine. And I'm not sure it matters where the fatigue is coming from. But if anything is new and it's severe, then go back and get blood tests. Ask to have your thyroid checked or whatever. But what would you like to say, Alan?
I think you know everything that we need to do. So fatigue also is very common in patients with PBC.
Yeah.
And again, I think there's a spectrum, right? So we start ruling out other things. So you mentioned thyroid. Thyroid, actually 30% of people with PBC have a low thyroid. That can cause severe fatigue. Mm-hmm. We will make sure that you're not anemic, but also, depression. Depression is a big symptom in patients with PBC because it's just basically a vicious cycle. You get really fatigued, you get depressed, you can't move. And I think you brought in, again, a great point. So there have been a lot of studies what to do with the fatigue. And I can tell you the only thing that works, there's a study from the UK. They looked at people who actually were called by a personal trainer, and they say, listen, get moving. And the people who actually were moving actually suffer less fatigue than people who were not actually having this encouragement exercise. Mm-hmm. So again, I would just advise people, just try to move as much as you can. Yeah. Rule out other things that can actually cause a severe fatigue. And then after that, there's other things that we might do, like antidepressive, because the depression is a big issue. But again, moving is the biggest thing in patients with PBC.
Mm-hmm. I think I'm going to add a wee bit here, given that I've had PBC forever, Alan. I know a wee bit about it, and I listen to people. I listen to hundreds and hundreds of people. Be mindful of your diet. I think one of the most poisonous substances on this earth is sugar. And I know that people will get hits from sugar or chocolate or biscuits, whatever, and you'll get a big low afterwards. Now, just be mindful. Sugar, processed foods will make you more tired. They'll give you a short lift. I've completely removed them from my diet. I was never a chocolate hand anyway. I don't have a sweet tooth. I'm very, very, very lucky. But be mindful that there's more that we can do for ourselves and review things, look at things, what do I do differently? Or maybe I should be doing something differently. Take charge, take ownership. And if you're struggling, phone me. A brilliant question here, Stephanie. Just one more question, if that's okay. Does urso cause weight gain? Alan is going to say no. Is that right?
That's correct. No, you cannot blame the weight gain to the ursodiol, unfortunately. But again, if you have PBC, the big one, just make sure that they check your thyroid. That's the big ones that, low thyroid can have pretty severe weight gain abruptly. So again, the answer to that question is no, unfortunately.
Right. Well, I'm going to be a bit controversial here. I asked that. I'd never had a weight problem until I went on to urso. But then again, I was tired, I was ill and all the rest of it. And they said, no. Well, Gideon Hirschfield up in Canada, many of you will know him from Birmingham. Gideon says, well, actually, yes. And some of the doctors say, well, yes, we think there's a likelihood. So who's to say? But I've recently lost a huge amount of weight. I don't know, in poundage, a huge amount of weight. And I didn't think I could do it on the urso, but I did do it. And I now take less urso than what I took before. So it can be done. You're just going to find out the best method for you. Okay, so I'm turning to Linda's sending me in the Facebook things now, everybody. So thank you for your questions. It's great to get all this knowledge. So this person says, I have COVID. Oh, I'm sorry. I'm really sorry to hear that. And I didn't think I would feel as bad as I've been double vaccinated and the booster. Is it so bad because the immune system is busy with my bile ducts? Can I just say to you, I've just recovered from COVID 2 weeks ago. My husband brought it into the house. He's still alive, by the way. It was very interesting. Like you, I double vaccinated and booster. And I've had PBC a long time, and I am not early stage. You wouldn't have known I was ill. And my husband, who's as fit as a fiddle and cycles 40, 50, 60 miles at a go, was really, really unwell. Now, I was speaking with James Newberger about this, Alan, and he tells me this is quite common. They can't seem to correlate what it is that causes some people to be more ill than others. And there was a feeling that people with PBC wouldn't get it so bad or don't get it so bad. But before you add in more, I read an article by Dr. Michael Mosley, who's he's a British doctor, and he goes on television and he talks about great things. And there's a study, I think at Swansea University in Wales, and they're basically saying that men whose index finger is larger than their fourth finger will get COVID worse than now. How true that is, I don't know. This is what came up. But anyway, I'll get your take on it, Alan.
All right. So I think the first message is I am happy that everyone is double vaccinated and booster, because I think that will prevent of that patient going to the hospital and that patient dying from COVID. That's the first thing. Again, is there any correlation within PBC and COVID? The answer is no one knows. But again, we've had a lot of surges here, also the same as the UK. And again, what we've known and what we've seen is people who get COVID, they really feel pretty bad. And it goes from, again, Collette, I had people who are completely asymptomatic and they basically have a little bit of a cough, to people who are completely wiped for a week or so. So again, it's like any viral illness, there is no way to predict. I think the only thing and only message that physicians that we can send out there is get vaccinated, get boosted, because that's going to protect everyone. So, I mean, that's the only thing that I can say about it. I don't know anything about all the things that you read, and I know, and I'm not a COVID specialist, but again, we've seen a lot of COVID here, and I don't see any specific, correlation between autoimmune conditions in the liver to the severity of the COVID.
Yeah, and as you say, it's viral. It's a viral illness. It's a virus, and viruses can be unpredictable, can't they? It's
right.
Yeah. Well, I hope you keep well and you get well soon. So the next question: I was diagnosed at Christmas, so I'm sorry. It would have been an awful shock, I'm sure. At that time, the alkaline phosphatase was about 950. It's now 380. Whoop! Gamma GT was 775, now 340. Fantastic. I know that's a huge improvement in our soul. How far down should they go and how long should it take? I've got referrals to King's College in June. That's a good amount of time. That's 6 months, isn't it? And of course, they will always look at trends. They will not take it from one blood test. But that's wonderful news, isn't it, Alan? That's what we want to read, isn't it?
This is great news. So I think in the PBC world, the most important thing is trying to get the alkaline phosphatase, as close as normal as we can. So we call it responders after a year of treatment. Most of us, I know that data might change in the future, but right now is we really wait for a year to make sure the alk phos comes down. But from 900 to 300, that's a great response. The things to consider is maybe getting an elastography, a fiber scan, to make sure that it has not caused any damage too. But if those both tests are coming down and the fiber scans are low, we've shown that the prognosis from that PBC patient is great. So you will have the same expectancy of life as someone who doesn't have the condition.
Yeah, it's wonderful. I'm delighted to read these things. Now, conversely, the next question is a jump in GGT from 250 to 1010 in 2 months significant, and what could it mean?
I think Collette, you used the word trend. So we don't want to use one set of blood tests as a marker of severity of disease. So we would like to say a trend. And what I usually explain to my patients is like a photograph, right? You don't want just a photograph because it's just showing you one moment of that liver condition. So you want to see 3-4 measurements. You want to see a trend. Sometimes viral illness, all the things would elevate your liver test without you knowing you have them. So what I'll say is make sure you follow up with your hepatologist, liver specialist, make sure they have another follow-up liver test. And if they don't find a reason, investigate and looking for other things.
And also, this is a wee bit controversial, but I'm going to say it anyway. And we're not pointing fingers at anybody, but we also know that weight gain can make a difference to liver function, liver enzymes. And let's be honest, we've all had an absolutely rotten, miserable time with lockdowns and COVID and living a life we'd never dreamed that was ever possible. And many of us, and me included, started to put a bit of weight on and do a bit less, etc. So it not necessarily be PBC, it can be other things, it can be viral, as Alan was saying, but don't blame everything on your PBC. But trends, get these tests done on a regular basis, and let's see what the hepatologist has to say about them.
I think, in Collette, one thing is not that the weight gain is, remember the ursodiol is basically dose based on weight and weight-based dose. So if you really gain a lot of weight, you want to make sure that the dose is correctly, because you could be underdosed for your PBC just based on your weight. So again, weight yourself, make sure that you have the right dose, because it could be that phos of that GGT is just going up based on your weight gain instead of being underdosed for your ursodiol.
It's a good point, Alan. We've got a small chart, laminated chart of weight in imperial and metric, and what you should be taking, and we've handed them out to everybody in the UK, and we've got them on our website, so please go to our website and you can check the weight, and it's in imperial and metric. I'm still working in imperial, I'm not doing metric anything, I'm too old. But I'll give you a good guideline. Okay, so next question. I started experiencing severe neuropathy from head to toe on the left side. Oh my goodness. I was completely numb for about 120 days. It has started to get better. However, the neurologist and gastroenterologist were not able to provide a diagnosis or a treatment. I've had an MRI, spinal tap, and blood work. A test was positive for cardiolipin, fat in the blood that's important for blood clotting. I or 1GM antibody, and at first thinking APS. I don't know what APS is, but I don't meet the criteria based on other blood work. Google searching shows this is positive in PBC patients. Any thoughts on neuropathy and or positive antibodies? I'm really sorry you're going through this. What a terrible, terrible set of symptoms here.
So again, I'm sorry that what they're experiencing. The answer to this question is, most of the times I don't see neuropathy as a complication or as a symptoms of PBC. My guess is, if you look at the literature, there are some reports about, the signaling and stuff. But again, this is not a common symptom or not a common complaint we experience in patients with PBC. So again, I will say I don't know the answer to this question, but I think a neurologist and someone looking into this deeply is a better recommendation than me saying this is related to PBC.
And it's good that this person is seeing specialists, and an MRI scan, spinal tap, blood work. I mean, they're obviously working hard to try and get to the bottom of what this is. And given, medicine isn't an exact science, but it could well be that they just need to keep plodding on and keep looking for the more and more and more unusual, and see if something could be found. And I'd be interested to know if this person has found anything by way of self-help, either heat or ice or movement or diet or anything, allergies. It's a really potentially big picture here, isn't there? But I do hope that they get this resolved sooner rather than later. I really do. And please do keep in touch. I'd like to know how you are. Okay, so the next one. I've been diagnosed with PBC for 2 years. Recently, I had a sudden increase in my C-reactive protein and my sedimentation rate. They are 3 times above the normal range. Can that be from PBC, or is it more likely to be another autoimmune disorder?
Again, I don't really test usually. I mean, patients who have PBC, I don't test them for the CRP and C-reactive protein. But I would say, I think the point is right. I think there's other autoimmune conditions I will look into to make sure there is no rheumatoid arthritis or anything else that would cause the C-reactive protein to be elevated. But again, the answer to the question is, I don't think they're related to PBC. But again, I don't test them frequently in patients with PBC either. So I don't know this is any correlation. Okay, but keep investigating, keep plugging away.
this person keeps getting group B strep in urine, very sick. I hear this is dangerous for PBC. Why does this keep happening? Group B strep?
Yeah, I mean, that's it's a urinary tract infection. Again, the first thing to know is I don't think they're related to PBC. Number two is I don't know what stage of PBC they have. Do they have advanced liver disease or they don't? So again, the severity really implies as the urinary tract infection. They can be that. This is a very common. I mean, it's not as common as the E. coli blogs or gram-negative blogs, but again, it's a common pathogen in the urine. So I would ask the general practitioner to treat it. And again, if there's more advanced liver disease, yes, this could be a little bit more dangerous because that can tip them over to have more decompensation. But this is a PBC patient with really mild fibrosis, just on URSO responding to treatment. I don't think there is any danger at all.
And interesting, this just brings to mind now, Gideon Hirschfield in Canada contacted me a few weeks ago and asked me if we could chat about, do we hear of a lot of people who get urinary tract infections, PBC people? And the answer historically is yes, we do. And I've spoken to David Jones and James Newberger. We're going to have another bit of a conflab about it. So Gideon was keen if we could maybe put together some kind of questionnaire and maybe just get some information together. But it does seem to be a bit of a common theme. And I'm sure the fact that we're women has something to do with that. But so whoever sent in this question, watch this space. And if you do see questionnaires, people, please do. Well, we've always got them running, but please do fill them in and complete them because it's extremely helpful. And when a doctor comes to us from Canada to say, can you help, then help we will, because this is PBC's worldwide, remember. So yes, I'd be delighted to but it's interesting, Alan, so we watch that space, eh? Okay, so 2 years ago, out of the blue, I had an emergency gallbladder removal, oh dear, with a dose of sepsis thrown in for good measure. Is there any connection between gallbladder issues and PBC? Oh yeah, we hear this a lot, don't we?
All right, the answer to the question is no. Remember, PBC, it's called intrahepatic disease, so it's actually the small ducts who get affected. So basically think about your immune system, your own defenses are attacking these small ducts of your liver. They don't actually interact with the gallbladder. So we don't have any correlation with gallbladder disease and PBC. Actually, if you think about it, ursodiol sometimes is a treatment for small gallstones. So if people have small gallstones, we put them on treatment with ursodiol. And then what we know, people with gallstones, when we stop the ursodiol, their stones come back up. So they come back and they start causing symptoms. So I would say the answer to that question is no.
We do hear it a lot, but again, when I was a young woman, they used to say, oh, fair, fat and 40. I don't know what the markers are or what the coincidences or what the stats and figures are, but we do hear it a lot, Alan. But it could well be, again, because we're women, we get the short straw. So we've got a question here. Is there any link to PBC and gastrointestinal problems, like increased bile or lesions in stomach and duodenum?
The answer to the question is no. So again, there's certain correlation within PBC and certain gastrointestinal disorders. The big one I would say is celiac disease. So people with PBC are more in increased risk for celiac disease, and microscopic colitis is another one in the colon. But none of those will cause any lesions or any kind of increased risk of malignancy. So for example, patients with PBC who have a lot of diarrhea, I really screen them for celiac disease. I send a TTG, which is the antibody, and sometimes I do an endoscopy or colonoscopy to look for other reasons. But again, because you have an autoimmune condition, you are at risk of other ones. So can you have inflammatory bowel disease? Can you have celiac disease? Yes. So you will have to rule all those out so you can make sure there is nothing else happening with the PBC.
So what are the most common autoimmune diseases, Alan, with PBC? Because PBC in itself is not common.
Right.
Yeah. So
I would say the biggest ones are thyroid disease. Sjogren's are the kind of the top two. I mean, I would say 30 to 40% incidence, which is pretty high. And then we go a little bit on the low side. Celiac disease is the other one. For example, I've had a lot of PBC patients who develop type 1 diabetes because of their autoimmune things. And I have a lot of PBC patients with inflammatory bowel disease that have developed microscopic colitis, or they've developed ulcerative colitis. They're not as common as the other two that I mentioned. But again, once you develop one autoimmune, you are at risk of developing another one. So for example, rheumatoid arthritis, lupus, you name it. But it's not as common as the top two that we've seen.
And the other question that we're asked quite a lot, and we've been asked again today, so is PBC hereditary?
Can you repeat that question? I lost
you. Is PBC hereditary? Can we pass it on to our children?
So the answer to the question is yes. I would say it's a multifactorial disease. So there is the genetic background. So if a patient comes to me and gets diagnosed with PBC, I would ask them to get all the females in their family to get tested, because there's a 20% kind of pass it along, I'll say, incidence, right? So if you have daughters, there's a 20% chance of you having it. But not everyone who has an AMA will develop PBC, so there is a trigger. It could be a viral illness, could be living, for example, if you look at the UK data, the US data, living close to high, trash zones, or like, for example, Newcastle is a big one, or in the US, for example, they looked at zones in New York City, and when there's a lot of, trash bins, they develop more PBC. And then there is all those theories. How do we develop an autoimmune condition? Again, we are predisposed of developing, but there's always a trigger. And whoever discovers that will be a millionaire, because really right now no one knows what all those triggers are. But for example, COVID has shown that a viral illness can trigger autoimmunity. We don't know why, but we've seen a lot of autoimmune hepatitis after someone had COVID. We've seen a lot of autoimmune bile duct injury from COVID. So again, anything that could be a trigger. So yes, I would say it's the genetic predisposition. So if you have PBC and you have females in your family, I would say siblings, for example, sisters, moms, daughters, they should be tested. The other question is what age should be advised testing, for example, your daughters. I would wait until 18 to 20, because I don't think there's anything to do before that. But I would say if they're positive, then I think maybe some people advise getting Ursodel. Some people will wait until your liver tests get elevated. But again, both approaches are actually okay. And I would say whatever we need to talk with patients to see what they want to do.
That's an interesting one, because I've heard various schools of thought, which is good that we can open it and let people know. So then some doctors I know do not want you to have your family female members tested unless they show symptoms, because of other issues. Example, insurance, mortgages, all these sorts of things, because it can stop you ever gaining life insurance. And when you're 20 years old and want to get a mortgage, that can be pretty serious. When you may not even develop the disease, you might have the antibody. So I think it's always got to be talked through, because there's various angles on it, nothing to do with health at all.
That's a great conversation we need to have with patients. And again, this is where kind of the patient-doctor relationship is so important. For example, in the US, they passed a rule that, you're not able to not get insurance by predisposing conditions, which is PBC, which be one of them. But again, I empathize with people who want to get life insurance and suddenly have a positive AMA, and then, maybe your quotes or your amounts that you need to pay will go up significantly. And I've made this life miserable because I test you for it. So yes, I agree with that.
Yeah, and in this country, Alan, if you have a diagnosis of PBC, there's no life insurance. You cannot get insurance. So I suppose that's why they're probably looking at it a bit differently here. And I would also go on to say that I'm not sure what happens in the States, but here, so you may have the AMA antibody and not have PBC, as Alan has alluded to. So they look for two things that you see here, without having to do a biopsy: the AMA antibody and an increased alkaline phosphatase. And that would certainly alert the doctor to thinking URSO, etc., and then start looking at bloods and what have you. But it's an interesting one. It really is. And of course, different sides of the pond, we do different things, which is great. Swap of knowledge. So I've got a last question here, which is great. It's a good one. Is it generally safe to have bariatric surgery with PBC?
Yes. The answer to the question is yes. I would say two things that you need to be careful with. Number one is, do they have advanced liver disease? I mean, do they stage 4 fibrosis? Because the risk of someone going to having an operation with cirrhosis is pretty high. So I would make sure that those patients get staged properly. And number two, after you get bariatric surgery, make sure you adjust your ursodiol. Again, if you gain weight, go up in the dose. If you lose weight, you need to, kind of go back in the dose. So that's one of the two messages that I would send someone going for bariatric surgery.
And also the fact that this person, God love them, who is needing the bariatric surgery, there's clearly going to be fat in the liver. Not that I'm a doctor, but that would not be helping your PBC at all. And this is happening all over the world, not just because of COVID, but because of processed foods. People eat differently these days. I mean, I was saying to Professor Jones a couple of weeks ago, I mean, my parents were alive during the Second World War, and there was food rationing for years and years and years. We had 3 meals a day, and they were very, it was porridge. I don't know if you have porridge over there. And homemade soups, you make lots of things with very little and very cheap, and no snacks. I was not brought up in snacks. Even now, I don't get snacks. But it's all changed now, Alan, and I'm not necessarily sure it's changed for the good in America. In the States, you've got obesity problems. Here in the UK, I think we've got the worst obesity in the whole of Europe. There is a trend going on there, and we need to fight back, don't we?
I mean, a great point. I would say we're really concerned about COVID, and no one actually has mentioned the obesity, which I think is worse an epidemic than actually COVID. Again, it's not killing people as COVID, but yes, it will be a problem. And I think one thing that you bring up, it's such a good point also, is PBC with a fatty liver, we call it two-hit theory. If you are inflaming your liver constantly from PBC, and then you throw in there the fatty liver, your progression will be faster. So instead, let's say you're not having anything under control, instead of that liver, trying to last 25, 30 years, you're basically you're shorting the lifespan for those organs. So for example, patients who drink alcohol, they have, they are obese and they have PBC, it's kind of a three-hit theory. So yes, we try to basically ameliorate or try to control all the risk factors that we can do to prevent that patient to develop cirrhosis. And that's one of them.
Yeah, and when we're doing it, we're not judging people. We're not saying, overweight people are bad people. People are overweight for a multitude of different reasons. Some of them psychological, emotional, and it's a serious condition. But I was watching a television program a couple of weeks ago on obesity and how it's affecting children, and they're talking about children needing liver transplants for fatty liver disease, which is just simply unbelievable, given, as I say, the way I was brought up without snacks, and food wasn't cheap and you had to make the best. And I don't know, I think it's maybe something we should keep talking about. Maybe we should go to nutritionists and get them to write things for people with PBC. I mean, us as a community, and I've got people watching here today, they grow everything, they cook everything, but it takes just a bit of time and a bit of planning. And I think sometimes with PBC, when you're tired, you're fatigued, and you just don't make that wee bit of extra effort. And I've found what's worked for me, losing a huge amount of weight, and I'm not saying a paragon of virtue by any means, is taking a little time out once every week or two to do a bit batch cooking and divide it all up, 400 calorie boxes, whatever, really good food, and freeze them. So those tired days, those busy days, just hand in the freezer and stick some broccoli in the steamer, and it's honestly it works. So even if we're older, we can change our ways. Honestly, we can. So we've come to the end of the session, which is great. It's in good time. I can't thank you enough, Alan. Really, really good questions. And I would say to people out there today as well, again, hi, Alan. I would say that, look, don't forget to donate to the foundation. We don't get government funding. We are quite a pure charity. You're welcome, Jeanette. And as I say, I'm not going to be here forever. I'm planning on trying to hang up my pen and my laptop and my box of Urso, but we will still keep. What was it Churchill said, Alan? We keep buggering on. My husband just sneaked in the door there, having been out in a cycle in the wind and rain. But Alan, thank you so much. You're coming from the States. What time are you there? You're early morning there, aren't you?
It's going to be 10 a.m.
So. Oh, 10 a.m. You're not too bad. Gentlemen, thank you very much. Linda, we've got all these people in the background doing all this stuff, feeding it to me. To everybody out there, keep well. Don't hesitate to phone us. Alan, all the best to you, and thank you.
Yeah, thanks a lot, Alan. We'll be in touch about the next time.
All right. Well,
okay.
I'll see you again.
Thanks very much, everybody.
Bye.
Thank you.
Bye.
Bye-bye.